I've hit several different points about starting and stopping resuscitation, and I think we have to at least address briefly DNRs here, right? Because that kind of sits somewhere in between DOA and field termination of
Sure.
there is this population that says, hey, if I'm not salvageable, don't even try, right?
Correct.
And but that in and of itself is nuanced. I don't want to do a whole do a whole DNR talk here, right? Because and I guess let's frame this again for the audience, right? Because we have two different types of DNRs here in the state of Ohio, right? We've got the DNRCC, which
Right.
is if there is or they're proceeding towards death, we don't resuscitate them. However, the DNR CCA, the CC arrest, is we do all interventions on these patients up until the point that they stop breathing or their heart stops, right?
Mm-hmm.
And sometimes those get blurred together, or honestly, I think more often than not, people just see DNR and then don't conceptualize anything that comes after it, right? They just saw those three letters and they're like, oh, they're DNR. I don't do anything. And here in Ohio, it's almost it's case by case, right?
Yeah.
Like Mark Rosanovich from the state EMS says, DNR is not do nothing. That's not what that is. And I think our protocol spells that out pretty well. For example, you're allowed to give oxygen therapy for a DNR. You don't have to let somebody drown in their own fluid.
Correct.
CPAP is absolutely appropriate.
appropriate.
Anything that brings them comfort. But you certainly would not be putting on a DNR comfort care on a monitor. You wouldn't be giving ALS medications. You certainly wouldn't be doing airway invasive procedures or compressions. So DNR comfort care is what it says, comfort care.
Make them comfortable. Yeah.
As opposed to DNR comfort care arrest is a little more complicated because they can spell out exactly what it is. They'll go because some are DNI, which is do not intubate. But other than I admit DNR comfort care arrest to the intensive care unit regularly, where you would think, oh, wait, that person's DNR. No, we're doing everything for that person until that situation arises where the heart stops.
You beat me to it, but that was a good example, right? That's what I needed. I wanted
we
the
operate
audience.
on DNR.
Yes. They go to the Catholic, DNR CC arrest, right?
Yep.
Because they're not dead yet.
Correct.
Right? So, and that's the important piece. Everybody has had that case where the DNR CC arrest and the squad phoned it in. Right, and they phoned it in. Now they're DNR. We don't do anything with these patients, or we do very little for them. And those you still optimize care on those DNR CCAs, at least in our neighborhood here in Ohio.
Yeah.
So so we hit that.
I do want to bring up something that has come up with one of my squads, and
Sure.
this is going to go back to talking about protocol. When we're looking at protocol, and I'm looking at whether it's asystole, whatever resuscitation is, first step is your universal patient care protocol. So gloves,
IV O2 monitor, glucose 12 lead.
Yep. Criteria for death, which we talked about, whether they meet those limited criteria, right? And then criteria for DNR. We're going to start CPR. We're going to establish an airway. And then the next step is capnography. I've had a few cases where they're putting on capnography. They've worked a patient for 20 hours. They worked a patient for 20 minutes.
Wow.
Yeah.
You are a
long time.
Yeah.
Yeah.
He's a real. He's really driving his cruise, man. Have you been there 20 hours? No.
No. Call me back.
Call me back.
Tomorrow.
I'll be in tomorrow. 20 minutes.
We're working a patient for 20 minutes, and their end title is 40. And so I think that I'm trying to get better at with my crews to talk about what that end title means.
Right.
An end title of 40 makes me think that there's active metabolism going on and that patient's salvageable. And if you call in with an end title of 40, you're going to be told to transport that patient.
Yeah, that's you're absolutely right. That's telling you something.
Yeah,
Metabolism, blood's going round and round.
Yep,
correct.
You know, you've got an intact plumbing system if you're getting that to the lungs to be off-gassed and sampled, right?
Yep.
Absolutely.
So understand that we have those criteria in place for reasons. And I've seen people on Lucas have really good
Absolutely.
end titles. We've talked about, and in protocol, that patients that are awake, I've seen awake patients with CPR in progress with Lucas devices. So I've seen higher end titles with Lucas, still under 30, typically 15 to 20-ish. But I understanding that if we're having an improving end title, or you have a higher than anticipated end title, you should probably just transport.
They're
that
trying to
patient.
tell you something.
Yeah,
Right.
exactly.
But
They might be salvageable. I'm not saying they are salvageable.
correct.
They might be salvageable.
They might be. And with a few exceptions, like they just got a bolus of sodium bicarb, right?
Yep, but if you're watching end title, you should see it come up and then peak and then come back down.
Right. So we're talking about a consistent.
Consistency,
That's the point I wanted to make. There is this isn't just a one-off aberrancy because of a medication or a procedure, an intervention, or something like that. So I've got this sustained capnography.
Yep.
And we said the words earlier, and I just want to feather this into what Dr. Hill is saying, is, you know, we took away the mandate of must have a CO2 less than 10 to meet the ALS field termination requirement. And I said it in another episode, and I'll say it again. You know, that number is still relevant from the perspective of if you have a resuscitation, this is really building off what you just said, and the CO2 is less than 10, then the converse of what you just said is true, right?
Correct.
I don't have metabolic processes. Blood's not going round and round. I'm not, off-gassing CO2. This is their cardiovascular system is collapsed, right?
Correct. If you're giving me a single-digit end title CO2 reading,
right.
I know they're dead.
Right. So, huge relevance in that number, although we've not made it an absolute anymore.
Right.
It's case by case, right?
Right.
I've had cases where we're doing resuscitation and we've had students in the room and I'm like, hey, we're going to learn some physiology today. We're doing resuscitation.
Right.
We're going to give bicarb. Watch this number go up, and then it does come down. I'm like, give more. It goes up. So I've understand that if it does keep going up and you're giving bicarb and it's not coming back down, again, signs of safe patient being salvageable.
Right.
And should probably come to the ER.
Unlike our conversation yesterday, in that case, you were winning your battle with hydrogen ions. So, yeah, that was a quote from a respiratory therapist last week that just resonated with me. He's like, I'm in a constant battle with hydrogen ions. And I'm like, I'm going to use that. I like that. I have two last bits here to kind of start us towards rounding this session out, and that is, how do we pivot? What extra considerations do we need to have for a crime scene? So please say, oh, they dead. They got shot. I was going to throw a mauling and shooting in there, but that too soon.
Survivability. It always trumps crime.
Great.
That being said, it's not something that we don't value.
Right.
So we try to minimize.
Is preserving the crime
right.
scene,
We try to minimize this disturbance to the scene, while maximizing patient care
and resuscitative efforts. Right. So don't send 47 people in.
Nope. Just one.
Yep.
One person goes in, touches the body, gloved hands, minimal disturbance. If the patient is prone, you can still put stickers on back in appropriate places and still get your 3 lead to confirm.
Absolutely. Yep.
You can still confirm lack of breath sounds. If you want to be really fancy, put your stethoscope on, put a glove over the bell, whatever you're listening to. You can listen for sounds and a gloved hand to check for pulse. Yep. That's all you need to do.
And if you determine they're salvageable, like you just said, all bets are off, right?
Correct.
Come on, we do the things. We do the things that we know we need to do, right?
And then documentation, just to pile onto that, or if you had to move that DOA patient in the crime scene, what did I have to do, and then be fully ready to explain that to the detectives that show up on scene or the coroner's office,
right?
And then follow that up in your report. It's going to be, if there's court proceedings, that could play into that as well. Did you move the body, or maybe you had to roll the prone patient over to see, and just document that.
It may or may not be, I just popped in my head, if you have police there, they've got body cameras on you, have them looking at you while you're doing your procedures. So that way you have video evidence of what you did, what you touched, what you moved.
That's true.
I would love for body cameras to be on EMS just for everyone's protection, right?
Yeah.
Mm-hmm. But that's not going to happen.
We're not there yet. Not there yet. The just a quick thought popped into my head. In Ohio, we've got this trend towards pre-hospital ultrasound. I know we're still a fair ways off from using it to do imagery other than vasculature, but do you think that would change? Would you be more comfortable if I said, "Hey,
that's a really interesting question"?
I had all these things, and I've got it.
I don't know if I could see live video,
and I've got a still heart. Right?
Yeah, if you could transmit a video clip of your still heart. Yeah,
I mean, how many times do we use the ultrasound?
A lot of times.
To look at the heart in the middle of a resuscitation.
Right. Or even just to make sure we don't have a huge pericardial effusion.
Right.
And that's why you're in cardiac arrest.
Right. I mean, this is a standard for us, and it's funny how many standards for EMS become standards for physicians, and then vice versa. So I love that.
I'm still proud that capnography was pushed from the field into the hospital.
100%. I gave those capnography lectures as a grand rounds.
Yeah.
And I can't tell you how many physicians came to that. Now, this is 10 years ago.
Probably because
it
was probably longer.
Okay, fine.
Pre-COVID.
BC, before COVID.
Okay. So the fact of the matter is, we led the tip of the spear on that one. For sure.
No, that was. But anyway, just that popped in my mind, and that of course ties in with your documentation. It's like I've not only do I have asystolic strip attached to my chart, now I've got imagery of a still heart, a video clip of a still heart. What else is there to say? It's totally slam dunk, right? Then the last couple things I have here is just more so beginning resuscitation, not resuscitation, I guess that kind of in that field termination vein of things. The blunt and the penetrating trauma cases, right? It seems like it crops its head up every couple of years. There's a case somewhere in this region where we're working a futile blunt and they bring it to the hospital and there's nothing to do, and then conversely there's penetratings that they're trying to field terminate and really deserved to be transported. So any thoughts on those cases, on how to help the provider kind of wrap their head around at what level is it appropriate to start resuscitating a blunt traumatic? Do we just resuscitate all blunt traumatics and just run it out to 20 minutes
I think just the opposite.
Or how do you what are your thoughts on that?
I think it depends, right? I think if you're coming into a scene, you don't know what's going on, the default
and I know this is not
resuscitate, right?
Yeah. Right.
If you then learn later on that they were in a car accident, that's probably unlikely, but obviously default's going to be resuscitate. Yeah. If you then learn later on, I think then it'd be early call to med control to say, I'm working in arrest, I'm 10 minutes in, but I just learned that they were part of a blunt trauma. Yeah. We just found them on the side of the road. We didn't know that they were ejected from a vehicle, right? Right. I think that changes.
My favorite, let's face it, blunt trauma arrest is not someone who's going to survive unless they've got 0%, unless they have, bilateral tension pneumos or a pneumo, and that's why we needle those chests on these blunt traumatic arrests. But I will tell you that every time I tell somebody it's 0 for a blunt trauma arrest, I think of a woman who was a blunt traumatic arrest on the Euclid Spur and Euclid Fire Department. You remember this case?
I know the case. Yeah.
I presented it. Yep. Euclid Fire Department did CPR on her only because there was a fetus involved, and they crashed C-sectioned the fetus, and the baby survived, and then they went to resuscitate the mom, and she survived.
That's crazy.
Yeah, she actually, from the blunt injury, bled out from a placenta abruption. and she received massive blood transfusions. Fortunately, they were 10 minutes away from the ER, and so time played a critical factor. I think she got dozens of packed cells and platelets and plasma. But my favorite follow-up on her was that she went to the cardiologist because she did suffer some cardiac issues from the CPR and everything, and her ejection fraction was normal now, and he couldn't stop talking about how healthy the little baby looked. So just when you say zero, there's always that story.
Yeah. So kind of two scenarios still in that blunt trauma mindset is, and I think the default is everybody's going to resuscitate. I walk on scene, they're peri-arrest, we're doing the things, and then they crump out on me after they've been ejected, after we cut them out of the car or whatever. I feel like every provider would just continue that resuscitation.
Yes,
and you should.
And you should. But what you said a second ago about needling the chest. All right, I come up on same thing, ejected. We cut them out, whatever. They're pulseless, they're apneic. Does that patient automatically deserve some sort of treatment bundle as a minimum setting? Do I, so we do put bilateral needles in somebody who's, a traumatic arrest.
Right.
That whole protocol still does exist. Do they deserve some, minimum set bundle of things to try first before we say, nah, it's blunt traumatic?
It's H's and T's again.
Yeah.
And I think that it goes back to understanding that a lot of things happen in parallel, but not instantaneously, right? The very first thing you're going to do in a pulseless apneic patient is you're going to start CPR, right? They need their chest needled, but you're still going to start CPR. So you're going to have CPR in progress while you're getting your needles out to needle the chest.
Right.
After you then needle the chest, probably should put an airway in, do all those things. You're going to be a few minutes into resuscitation. You're going to have a much clearer picture of what's going on because who knows, you might place that airway and their end tidal might be 35 and you're now getting a more organized rhythm that you can work with and they might be salvageable. You just don't know. But it's different if you start CPR, you needle their chest, you put an airway in, their end tidal's 10, 15 even, and it's asystole on the monitor. Those are different presentations of patients.
And then what if, and just, again, this is discussion, we're not going to hold anybody to this, but what do you guys think about an empiric liter of fluid on that patient and empiric pelvic binders on those patients?
I think so.
Personal opinions. It's just for discussion.
So trauma has changed their tune a little bit. They only want a maximum of 1 liter on these patients because they don't want to dilute out the hemodilution.
Right.
So I think a liter is okay. Again, if you're putting 18s in a patient, then you can load that in. You
Squeeze it in.
Squeeze it in. You can pressure bag it. You can do whatever you want. You can get a lot of fluid into a patient pretty quickly. I don't think you need a pelvic binder in all these patients if it's a stable pelvis. If it's an unstable pelvis, absolutely.
That's unfortunately pretty easy to tell. Because if you are doing that and it's unstable, you probably shouldn't have done that. But it is what it is.
Yeah. Well,
it's like finding out.
I've seen some people just recommend it. It's like,
but also, what's it going to hurt, right?
Correct. That was the angle, right? Is just I'd rather have done it and not needed it in this patient that's ultimately going to be terminated anyway.
And that's why I give everything for cardiac arrest.
And I think you and I discussed at length a pelvic binder case, right? But but
C-collar and all.
Absolutely, what I didn't hear come across from the other side of the table is it's an absolute must.
No, it's not.
That's you can use clinical judgment and your assessment techniques to determine if it's reasonable and appropriate.
What's unfortunate from a learning perspective is if I identify a open book pelvic fracture, I can't then say, "Hey, student, press on this."
This is what it feels like.
Well, survey in the room: who's felt an open book pelvic fracture? You guys all have, right?
Yeah,
of course.
But we've also been doing this a few years, right? The new guy, I want to be able to teach them or her. This is what it feels like, and I can't do that. Yeah. That's the worst thing for the patient. So, from a learning opportunity.
Yes.
And again, kind of going back for these patients, if it is, let's say it is a traumatic arrest, maybe that's someone that and you think it's going to be a good airway, going back to our airway series, that you have your new person tried to intubate, understanding that this person's unlikely to be salvageable, that they can get practice on.
Get the reps.
Get the reps.
So, fantastic. I think we're wrapping this one up. Anybody else have any thoughts on any of this down in the DOA field term stuff?
I thought those were
we got some
great questions.
Great discussion on a multitude of things.
Yeah, I agree.
All right.
I think it comes down to know your protocol and review your protocol. Yep. If you're going to a down patient, maybe review what our protocol states about either DNR, resuscitation, what you're going to follow for asystole, what you're going to follow for VFib, VTAC. Just kind of know your protocol. If you're not university hospitals, review whatever protocol you're operating under, so you know what you're supposed to be doing. Know you're just.
I heard touch your patients, right? You
know
actually
your
have
protocol.
to physically interact with your patients, right?
Touch your patients. We're checking for when we're assessing our patients for a pulse. You can feel a pulse right away, great. If not, make sure you're checking central pulses, so carotid or femoral. I feel carotids are a lot easier to detect than femorals. I even find issues when when we're doing CPR in the emergency department, you'll often see the ER doc with a hand on a femoral pulse, right? Just to make sure I can feel compressions. I can feel a pulse with compressions, and I know they can stop, and then I can make sure that I can quickly determine whether or not there's a pulse, and I can call it what the rhythm is, and then we can restart CPR as soon as possible, so we're minimizing time off the chest. That's high-quality CPR. So obviously, touch your patients. Make sure you're listening and auscultating the lungs for respirations. Make sure you're doing that 30 to 60 seconds. And make sure you're obtaining your multiple leads to make sure that lead's just not off. Look at all your leads. If you're a basic unit, you're going to have to do a 12 lead in transmit. That's okay. We're just verifying in 12 leads that the patient's asystolic. Yep. And it's really easy. I mean,
and give a succinct report to the physician.
Yeah, absolutely. All right. Well, thanks everybody.
Thank you.